Hello friends, this is Dr. KV Singh, and in this particular case I'll be demonstrating you a case of NS 3 grade cataract which was preintumescent in nature, and I'll be demonstrating my horizontal chop technique in this particular case. By this time I've already made my side ports, and I'm using intracameral 1% lignocaine as a choice of anesthesia. I do all my cases, almost 99% of my cases under topical anesthesia only. So this was done under same, and it is possible in case there is no other complication, then we can do all our surgery under topical anesthesia. So because this was a case in which there was no red glow present, so I used a trypan glue dye to stain the entire capsule, and now I'm refilling the AC with visco, and now I'll be making my main port. I make all my main port incision biplanar. I don't believe in triplanar incision as they're difficult to construct, and at times the architecture becomes bad if we have to take out our phaco probe repeatedly. You can also appreciate one thing in this case, that I have put a cotton wick in the inferior fornix, because this case the eyes were very deep set and it was causing a lot of pooling of fluid in the eye. So this is a very good way to get rid of that fluid without using any suction. I just put a wick in the inferior fornix and that takes care of stuff. Now I have already initiated my Capsulorhexis using 26 gauge bent cystitome needle, and at times these are pre-intumescent case, so rhexis runout can happen. So we should be ready with our forceps. In case we get a hint of rhexis runout, we can take it and bring it back. That's what I did in this case. I used Inamura forceps to bring it back and make a CCC. Now this is a pre-intumescent cataract in which there is not much of cortical matter left. So while doing hydro dissection, we have to be very careful. We must use only small aliquots of fluid to achieve the hydro dissection. So now I'm ready with my phacoemulsification. My parameters generally are 400 vacuum, 35 aspiration flow rate, and my phaco power is around 60%, which is continuous, which I able to modulate with my foot switch. Now I have done the direct first horizontal chop. I use a 2.5 mm ball tip chopper. So basically I use two choppers. One is 2 mm, one is 2.5 mm. In case I have a very hard cataract, something like this, and a bulky nucleus, I use a bigger chopper. For smaller and softer cataracts, 2 mm ball tip chopper suffices. So before engulfing, I like to make as many as pieces as possible in these cases, because what happens that these pieces themselves act as PC protector, and they bears down on the posterior capsule and they protect the PC nicely. And with the chopping, in case the bag is full, the chopping is also easier. At times what happens that the overcrowding of bag can happen due to the pieces, then we can engulf one or pieces just to make the bag less crowded. Now I've refilled. After I completed all the chops of the nucleus, I am starting to engulf the nucleus pieces, and you can see my side port instrument is just holding the eye in the primary position, and my phaco probe is also staying in the middle. I'm just using small burst of phaco probe to cause the emulsification. So if you have achieved multiple pieces of the nucleus, then this becomes very easy, and you can also do your case in this way. Because this was a mature pre-intumescent case, so not much of cortical matter is left, and I can directly go ahead with the implantation of IOL in this case. And generally I implant my IOL under irrigation only, but in this case, because there was some degree of zonular weakness was also there, so I decided that I'll put the IOL under visco only. So this was a push type injector, simple monofocal aspheric lens, a very good lens. I will not be telling about the brand because I have no financial this thing, but generally monofocal aspheric lenses are sufficient for all the cases. Patients are generally very happy. You can see the floppy nature of the iris has started to become evident now, and we can see, but I'm not going to disturb that iris now. I'll first evacuate the AC with visco, and then I will do it, because repeated manipulation of iris can lead to iris damage. So my visco evacuation has already happened, and now what I'll do, I'll simply slide the iris back. I'll depress the posterior lip of the main wound, and that will keep the iris inside the wound. Now I'm closing the side ports with stromal hydration. Thank you guys. Thank you for watching this video. In case you like, please drop a comment. Thanks for your time. Thank you.